you don't have to dissect further, even then this axilla is taken care of. The internal mammary and supraclav areas is not routinely addressed by surgeons. If at all, it is indicated by the location of the tumor or size or nodal positivity, then radiation is the standard treatment. How do we do sentinel node? We all know of two techniques, blue dye technique and radioisotope technique. So the combination of two, in blue dye we do either methylene blue, isosulfan blue or patent blue, and in technetium is used for the radionuclide scan. So what happens, we take this patient to the radioactive nuclear medicine department where the technetium is injected on the same day of surgery, 2 hours prior to surgery, and then on table a blue dye is injected. I will go through these slides later on. And once you have got a node which is both hot and blue, that is the representative node. One must make sure that once you have taken a sentinel node, a group of sentinel nodes, you should not have any hot node. There should be no sound, or if at all it is less than 10% of the highest value which have in the axilla, or no blue node should be there in the armpit. So all such nodes should be picked up, and it is proven beyond doubt in multicentric studies that the false negative rate is quite low if you are using the dual technique. However, the surgeons should be well trained. They should first have a proper training and make sure that they have 20 odd cases where they have done both the sentinel and the axilla and got a low false negative rate. Beyond that, there should be a regular practice in that, because you have done one off or you have done for a year or two and then not in practice. And if the node was positive, then you do a sentinel node dissection. And over a long period, over 6 years period, they found that almost 60% of these patients who had node positive had only one node positive in the axilla. So probably there is a scope that we can avoid any subsequent intervention in a large number of these patients. The risk of positive lymph node grows up in the presence of lymphovascular invasion. We also know that the risk of positive lymph node is decrease in the number of nodes picked up is high. 3 or more nodes is a good enough reason to have that we have a most good sensitivity. And the morbidity is low, though there is a learning curve to all this. So they also came out with a guideline to say that for the that if the sentinel node has macromets or micromets, a completion ALND should be done, and that is what is a routine we have been doing till now. However, we all know of this trial Z011 where they said the axillary dissection versus no axillary dissection in patients who had sentinel node metastasis. Now, what they did here, they randomized these patients, only those who have had breast conservation surgery. Now, this is where an important catch is, because in our practice, BCS rate is not as high as in the Western world. Now, once the BCS is done, if the nodes are positive, then they are randomized into axillary lymph node dissection completion or no further surgery. The idea was to study the effects of ALND on overall survival with sentinel lymph node positive patients with lumpectomy who are also having adjuvant systemic therapy. We know node positive patients will have definite systemic therapy and also radiation because of the BCS and also node positive today. The secondary objective obviously was to determine the effects and disease-free survival on the overall adding ALND to these patients. And the inclusion criteria, T2 downwards, T1 and T2 disease, no palpable lymphadenopathy, no and unicentric united disease, lumpectomy with negative margins as is the goal for the primary wide excision, and 1 to 2 sentinel node at least containing metastatic disease. They excluded the patients who had more than 3 nodes positive and or those who had extracapsular extension or those who had neoadjuvant chemotherapy or endocrine therapy. So once this subset of patients was identified, then the patients were categorized into those who had 1 node positive, 2 nodes positive or 3 or more node positive. And these patients, as you are seeing the blue bar, that those who had full lymph node dissection and those who were trusted only with sentinel lymph node. So we see there is a comparable figure on both the arms. There were a comparable number of patients who had either completion axillary dissection or did not have any axillary dissection. And what did they find at the end of 6 years? That the recurrence in the ALND group was also quite low. In the local area, it's about, ALND group was about 3.6% in the breast, and in the sentinel node group alone, that means those who did not have a completion axillary dissection, about 2%. And if you look at the total control rate in the axilla, that was about 4% versus 3% in the 2 arms. So the axillary lymph node dissection patient group did not have any superior advantage over those who have had only the sentinel node sampling. And this is just to show that in the tangential field how the axilla is covered, the lower part of the axilla is covered in that. So that is adding to the improvement in local control rate. The 5-year survival rate and disease survival rate was also quite comparable in the 2 groups. So the conclusions were that SNB alone provides excellent localizable control comparable to SNB with completion ALND in patients with T1, T2 disease who have 1 to 2 nodes positive and who are going subsequently for adjuvant systemic therapy and radiation also. Now the third important question is whether there is an opportunity to actually avoid excision completely with radiation. Now this is a very important AMROS trial where they did a trial of patients in T1, T2 breast cancer with no palpable lymphadenopathy, and they randomized them into an open label study where they grouped into either axial dissection done or only radiation given to these patients. The primary endpoint was that a non-inferiority trial was there, that comparing whether radiation is not inferior to axial dissection. Out of this 4,823 patients enrolled from 34 centers, 486 were actually eligible for the randomization. Now 240 were randomly assigned to receive axial lymph node dissection, which is the standard of care as of today, and the remaining were subjected for radiotherapy. Now of these 1425 patients with positive sentinel node, now this subset had sentinel node, positive sentinel node, 744 were assigned for completion axial dissection versus those who had only radiation in this group. Now at again 6.1 years, they found that patients with positive sentinel node in the axial lymph node dissection group, 222, who had underwent axial lymph node dissection had additional positive nodes. Somewhere around what we saw in the previous study also, that about 60-65% patients only had that sentinel node positive and the rest of the axilla was clean. Here again about 33% who have additional nodes positive. The axillary recurrence occurred in 4 of these 744 patients. Now in spite of having axillary complete dissection, 4 patients had axillary recurrence and 7 of the patients who had radiation therapy. The point is that almost similar number of patients would have axilla positive post sentinel lymph node. Now in that subset, if you give radiation, again the failure rate is quite comparable. You will not go ahead and do a complete axillary dissection. Now 5-year axillary recurrence rate was 0.43% with patients. Clinically negative nodes for axillary dissection or axillary radiation. This was long back, and there again they found that the follow-up showed a slight increase in axillary recurrence with radiation therapy, 3% versus 1%. So no this difference in overall survival or local regional control. Now what is the, today we have sentinel node, a couple of nodes to check. So we go in more detail and assess these things more carefully, and what we find that we all know of pathologically node negative group, but in the node negative group, sometimes you have a positive on immunohistochemistry. And if that cluster is less than 0.2 millimeter in size, that we say is less than 200 cells, then that group is called isolated tumor cells. And there the value of going or treating them as node positive is under big question. So as of today, the recommendation is that only those patients who are showing micromets, that is more than 0.2 millimeters and not more than 2 millimeter size tumors or node positive should be treated as node positive, and the rest is treated as node negative. So the presence in sentinel node is of unknown significance. At present, no further surgical intervention is required in these patients. Now what to do if the sentinel node is positive for METs and you have closed the axilla? Now this is something where we can safely say that all those who have isolated tumor cells, we can avoid subsequent intervention without any fear. In 1 to 2 node positive, you have to make sure that this patient is getting subsequent radiation. Otherwise, you must go in and take care of this. In all other situations, you have to go in and revise the axilla to a completion lymph node dissection. So if I can say that the take-home message would be that ultrasound should be considered as an extension of clinical evaluation today. Sentinel node should be considered a standard of care for patients who are node negative on axilla clinically and on ultrasound. ALND should be done for patients who are positive on sentinel node unless you are making sure that radiation is added and the completion is done. The presence of isolated tumor cells should not warrant any intervention or planning of treatment based on this as node positive. It should be carried as node negative. The role of sentinel node after neoadjuvant chemotherapy is coming in vogue. We are also doing a very few select cases. We are informing our patients, but widely it should not be practiced, should be carefully assessed, and more data is required to suggest radiation therapy as an alternative to management of axilla versus surgery. Thank you very much.
Thank you so much, Dr. Hari Chaturvedi, for a very...
I have a question. That are you routinely doing scintigrams in your sentinel lymph nodes preoperatively? And if not, what are the indications of doing scintigrams?
Can you hear me? Can you hear the question?
Scintigram.
Can you come forward and please, we can't hear you well.
Question is, are you doing scintigrams?
Yeah.
Yeah.
So routinely we are not doing we are doing not doing scintigrams routinely. Yeah.
And are you doing in recurrent cancers or repeat surgeries? Sentinel node?
No sentinel node in recurrent surgery. In fact, in all redo surgeries, it's always a completion mastectomy with full access.
Any more questions? And do you have any questions? Yeah.
Good. I enjoyed your presentation. What would be your recommendation? Because the vast majority of centers in this country cannot afford a sentinel node. Do you recommend in such circumstances blue dye guided sampling?
So this is something which comes up in every conference about talking about blue dye. I am not a proponent of blue dye alone, because see, we are taking a risk because the false negative rate goes up, and number two, the advantage of sentinel node is that once you have a gamma probe, you actually take your dissection bang there on the area where there's the sound is there, and then you can dissect the very small area. However, there's data to support that lower axillary dissection level, picking up 4 nodes in the axilla and finding that subset which Tata Group has done is showing promise. But to recommend it unless it's formally properly trained, I would not recommend it. And in blue dye alone, you end up dissecting too much of axilla. So the advantage of not interrupting the axillary flow is lost.
Yeah, but at the same time, Dr. Chaturvedi, there are many centers who do not have the technetium or the nuclear medicine facilities. So I think if they do a blue dye, and if they don't find the blue dye, they should be more liberal in looking at the axillary dissection rather than saying, oh, this looks like blue. If they don't find it good blue dye, blue lymph nodes, should they go? I mean, this is one way of doing it. And many centers in America, I think, are also doing just blue dye alone. I mean, most will do double, but
my only fear in all these things is that it should not be taken as acceptable in a broader sense. If one is doing and aware of the breast management totality and doing it well, then probably it's worthwhile. Because these are significant implications.
Yeah. I think we're finishing with the time, but can I just ask you one more question? He said in those where sentinel lymph node is positive, 1 or 2, and patient is having a breast conservative surgery, there is no need to do axillary dissection because radiation covers level 1 lymph nodes. Can you also tell me, is it only done in good histology tumors or can it also be done in a bad histology?
So it should be favorable histology, ERPR positive, select group of patients. Yes.
Yeah. Okay.
Thank you.
And thank you so much for a very encouraging and a detailed talk. Thank you.
Okay, we are coming to the third paper, oncoplastic surgery, indications and techniques for CF breast. And this will be presented by Dr. Arya Jyoti from San Diego, USA. Dr. Jyoti, please.
While she's reading the slides, you know, oncoplastic surgery is another very hot topic in breast cancer. Earlier, we would take the lump out, close the skin, let the cavity fill up with seroma. That's actually no more acceptable because the seroma heals and you always feel there is a recurrence, etc. And now with the oncoplastic surgery,
can do. This patient's approximately 43 years old. She had a relatively small tumor in the outer lateral aspect of her right breast. She has a small scar, minimal deformity of her breast, and really can move on with her life. In fact, she came to me requesting a breast augmentation, had nothing at all to do with her breast cancer. She's kind of moved forward. And this is an excellent example of how nice breast preservation can be for some people. This is another patient. She's 54. You can't even see the scar on her right breast. She had an area of invasive disease. It was a central tumor, but it was very deeply based. She had enough excess volume on her right side so that even after her surgery and irradiation, she looks very, very similar. It was only after her sister was diagnosed being BRCA1 positive that she came to me. Now we went forward and did bilateral mastectomies. So this is, again, an excellent example of what breast preservation can do. But this is an example of where we're beginning to see the larger lumpectomies and a small degree of deformity. Now, from the frontal view, the patient has, I think, an excellent cosmetic result on her right side. So she's asymmetric between the two breasts, and so she's always worn a small pad in her right breast, and that's been fine, and she's been very happy with that. This is the lateral view, and again, although that scar is somewhat deforming, it's in an excellent location to be well camouflaged, and so in most clothing, it's almost never visible. Even in a sort of standard bathing suit, it's pretty well covered. She unfortunately went on to develop a second tumor in that right breast and went on to have additional surgery. But this is where you begin to see some of the difficulties with larger tumors resection and some of the deformities that happen with lumpectomies. Now this patient had a 3.4 centimeter tumor. She insisted to my general surgical colleagues that she didn't care what the breast looked like, she just wanted the tumor out, she wanted to preserve her breast. Well, after this, even with the clear margin, she was very, very unhappy, and so before she went on to radiation therapy, we went ahead and did a bilateral mastectomy to treat this. And that's a very long conversation for another topic, but this is where lumpectomies are beginning to start to fail. Some of the larger tumors in patients who have a significant degree of breastosis, patients whose nipple-areolar complex, or the NAC, is no longer in the appropriate position. So this is another patient. She was very young with her initial tumor. Again, she didn't really care, just go ahead and take it out. But as she's now 15 years after her original surgery, she's really unhappy with her scar on the left side. So this was in preparation of, again, a bilateral mastectomy moving forward. So with some of the early initial excellent results from lumpectomy and some of the later results as lumpectomy was sort of really incorporated into practice, we saw some of the few downsides and some of the contour defects that were made patients unhappy. So when we look at patients who are set up to have a lumpectomy, you're kind of working on the premise that you'd like to continue with breast preservation. You really want to look at the volume of both breasts, how asymmetric they are. Now this individual patient has already had a lumpectomy on her right side and radiation therapy, but if, say, she hadn't, there's lots of women who have this degree of asymmetry, which is pretty normal. So what volume of breast tissue do they have? How symmetric is that? What degree of breastosis do they have? Or how much has the breast fallen below the inframammary fold? Where is that nipple position? If the nipple's in the wrong place, you certainly don't want to preserve it. You need to move that so that in the long term, her aesthetics are improved. And then has she had previous scars? That'll dictate how your skin envelope will heal after the mastectomy or after your planned lumpectomy, how you can rearrange the skin if needed, as well as if they had previous radiation therapy. And then you also have to ask the patient, what is her goal? She's had very large breasts her whole life. She's happy to be smaller, but she's a larger person and she didn't want to be too small. So she went on to have a mastectomy with reconstruction. Now when you look at this, her therapeutic goals have been somewhat met. Her symmetry is okay. Her right breast is actually still slightly larger than her reduced left breast. The nipple-areolar complex position is too low. It should be a little bit higher. And this is also a good example of the tattoo ink is not very good ever. Most surgeons don't actually get into the tattooing. It kind of gets dismissed or sent off to somebody else.